people have joined from all over the place. And we are just preparing ourselves to get to the session. Yeah, as we still connect our main speaker for today, who is going to be Dr. Rachel Kamau. So you are all welcome. Again, as you well know, these are sessions that are ongoing. So we actually request and require that everybody registers at every moment, so that at the end of the trainings, we can be able to assess the number of sessions somebody has been able to attend, for them now to be qualified and competent for the curriculum the way it had been set out. So all of you are welcome. Kindly make sure that you also attend the future trainings that are going to be offered, so that now you keep abreast with all the presentations that are given as per the experts who have been chosen and volunteered to capacity build our healthcare workers. We know that the objective of all this is to build the capacity of our healthcare workers wherever they are working, so that now the same can be cascaded to all others who work under them. So as you attend this one, yeah, you also make sure that you're able to train the others who are below you to be able also to be as competent as you are. So IPC is for all of us in the healthcare sector, and each one of us should be able to adhere to IPC practices. I know most of you know what happened around December and January, when we had the outbreak of the cold that actually most of the healthcare workers were infected and affected in one way or another one. So we cannot let down our guard, but we need to keep it up as always and at every moment. So some of the actually practices that we could see that had actually lagged behind, one of them was issues of just simple procedures like hand hygiene and why it is important and all that. So for you even to be able to talk to others, you need to be very much aware of what are the aspects and why it is important actually for each one of us to be performing hand hygiene, among us many other IPC practices. So today that our session will be covering on that. And as we wait for Dr. Kamau to connect, I would welcome each one of you. And I think, Romina, you'll go through the slides for the Zoom etiquette, so that now we can again remind ourselves of the Zoom etiquette as we proceed on with the presentation. So I will give around 3 minutes, and then Romina, you will run through the Zoom etiquette slides, and then from there we can start.
Sure, Eric, just a confirmation. Do you want me to run the housekeeping slides right now or like in some time?
I think you can run them right now.
Sure.
As we wait for Dr. Rachel. Dr. Rachel, have you connected? Are you able to speak? Dr. Rachel, can you confirm hearing us? Because we can't hear you on your side. Okay, Romina, let's run the slides for housekeeping. I think there's also one of the participants who cannot hear us. I think that is Clarice Jumbale. I'm hoping you can hear us now, Clarice. If you can just put your thumbs up so that we can be on the same page. So I will allow 3 minutes for running of the slides on housekeeping. Romina, you can run them a little bit slower so that people can read. So 3 minutes for that, and then we can dive into the presentation with Dr. Rachel. Thank you. Highlight. I've seen your message. Yeah, you're actually asking no sound or nothing running on the screen. Yeah, we are running the Zoom etiquette slides as we wait for Dr. Rachel to connect. So we want to give her a minute or so just to connect, and then we proceed on. Thank you, and over.
Kama sana naye mama kauti. Kwa na ule mzee. Huyo mzee hata mzee ndio mnaongelesha tu kusichana kama amepata mimba. Yaani mpaka mama huko anasema jamaa mama anasema ati msanii anasema kama hataka kuua dada yangu. Sasa mimi sasa nifanyie
Hello, Dr. Rachel, can we try your voice now? Try to join using the phone.
Eric, sorry, Dr. Kamau is still having issues with her connections. So Dr. Koech will do the presentation first, and then Dr. Kamau will join in a little bit later, if that is okay.
Yeah, that's okay. We already have Dr. Koech.
Good afternoon. Eric,
Hello.
kindly confirm if you can see my slides.
Yes, yes, Dr. I confirm we can actually see your slides. Thank you for stepping in for Dr. Rachel as she actually tries to connect. I know sometimes internet can be a problem. I think she's going to drop off a little bit and then come back again. So yeah, we can actually see your slides. Thank you for coming in. Actually, Dr. Koech is from Kitale County Hospital, and he's just going to give us an experience and a journey from Kitale County Hospital on hand hygiene practices. So Dr. Koech, I think I'll just welcome you. You can do a personal introduction and then take us through the slides. So karibu daktari, and let us proceed. You can actually try and put it on slideshow if you can. Are you able?
Yes, actually it's on slideshow on my side. I don't know if you can see it on slideshow on the other end.
No, we're actually seeing the presentation, but it's big enough. I think we can allow you to proceed like that.
Kindly confirm if the slides are moving.
Okay. Yes, they're actually moving. We are now on background and hand hygiene infrastructure now. Yes, and then back to the beginning of the slide. So they're actually moving. You can go ahead.
Thank you very much, Dr. Nancy Koech. From Kitale County Hospital. I'm the AMS focal person and also the chairperson of the IPC committee at Kitale. And today I'll be sharing our journey, our hand hygiene journey as Kitale County Hospital. So the IPC program in Kitale started in 2016. And in 2017, we were privileged to have a 3-year IPC program that was supported by the Ministry of Health, CDC, and ITEC. The program ended in 2020 in September, and hand hygiene was one of the critical elements of the IPC program. In 2016, we did a baseline survey on our hand hygiene compliance, and we were at 3%. So currently, in terms of hand hygiene, our hand hygiene infrastructure, at the various departments, at the casualty, we have a total of one sink with all the hand hygiene supplies. We also have one alcohol-based hand rub that is functional. In the female medical ward, we have 6 sinks, but it's lacking the power, but running water and soap is present. We also have 6 functional hand alcohol-based hand rub. In the medical ward and surgical ward, we have each has one hand washing point and 2 functional sanitizer dispensers. In our maternity unit, we have a total of 10 hand washing sinks and 8 dispensers for the hand rub. The labor and delivery ward, we have 3 functional sinks and 3 sanitizer dispensers. As you can note, majority of the hand washing points lack the the paper towel for performing hand hygiene. The female surgical ward also has four hand wash points and 3 hand rub dispensers. The renal unit has 4 dispensers and one hand wash point. These are the point of care. The pediatric ward has 5 sinks with 2 dispensers, while the gyne ward has only 1 hand washing point and 2 alcohol-based hand rub dispensers. The newborn unit and the outpatient department each has 3 hand washing points, with the NBU having only 1 dispenser for the alcohol-based hand rub, and the OP has 5 dispensers. So when we began our IPC journey, as you can see in the picture, this is where we started from. Our sinks were not in very good conditions. They were dirty and not well maintained. But currently, we maintained and cleaned with running water and soap available. This is also an example of, we had so many of the hand washing points were not functional, but currently the situation has improved and we have functional hand wash points. So we were also able to get an installation of a hand wash point for our clients in the X-ray department. We also had another installation of a hand wash point for our patients at the outpatient department with the soap available and the elbow operated taps. This is also the emergency unit and the OPD with the alcohol-based dispensers have been installed. As the IPC team, we oftenly do hand hygiene demonstration and on-job trainings to our healthcare workers to inform them of the importance of performing hand hygiene. So we conduct hand hygiene audits at the various departments. We usually do them monthly. And the areas that we usually assess include the female medical ward, the male medical ward, the surgical ward, that's both male and female, the maternity, the renal unit, pediatric, the emergency departments, the laboratory, and the outpatient department. So for our 2019-2020 data, this was our performance in hand hygiene. At around March 2019, we were at 59%. In May 2019, we were at 10%. But after that, we increased gradually. But as you can note, from around February 2020, our performance was above the benchmark of 50%. And this was contributed a lot by COVID came in around that time and people were more compliant with performing hand hygiene. So for 2020, we were above the benchmark that we had then of 50%, with the highest being April 2020, we were at 79%. In 2021, between January and May, we were not able to conduct the hand hygiene audits because there was strike around the hospital and the staff were not around. But from June, we have data from June to December 2021. June, we started at around 15%. This showed how much we dropped from our performance in 2020, and we increased gradually. By December 2021, we were at 52%, and we were below below the benchmark that we had for 2021 was our good performance in 2020. So generally for 2021, our hand hygiene compliance was not as good as before. In terms of the compliance per cadre, we have the different cadres, the nurses, the doctors, the auxiliary, those are the students and other staffs. So as you can see, were 100% compliant with hand hygiene with the various cadres. They were around 50 to 40%. So after we conduct these hand hygiene audits, we usually disseminate the findings to the various departments for comments. So, and we display them in the notice board so that they be seeing how they are performing as a department. So far, in terms of hand hygiene, our successes have been, we've had support from the management in terms of supporting the IPC activities. We also have a very committed IPC team members who are able to take out, including the day-in roles in the hospital and also include the IPC activities. We were also able to commemorate the IPC Week 2021, and our focus was on hand hygiene. Currently, we are trying to build up it, and currently we have 3 full-time staff. That's we have the IPC focal person. We also have the AMS focal person, who is also the chair of the IPC committee. And we also have a class who assists us with data entry. We've also been able to conduct continuous trainings and CMEs on IPC, and we've had a constant supply of soap and water. Our challenges is that the IPC committee team members are having a challenge of having multiple tasks. So we need additional full-time members to the IPC unit. We lack proper hand paper towels in most of the departments. And the new staffs in the institutions majority are not yet compliant with hand hygiene practices. Mostly the interns who have a high turnover, they come in every now and then. We also have frequent staff changeovers, which is both internal and external. So it becomes a challenge being able to train and the hand hygiene practice with the high changeover. Some healthcare workers also did not adhere to the hand hygiene practices despite training. So we also have an attitude problem where majority of the healthcare workers are aware of the importance of hand hygiene, but they fail to practice it. And the IPC work plan budget is often not fully met to facilitate the IPC activities. On the way forward, we intend to continue with the on-job trainings on hand hygiene practices and to formulate policies for the new staffs and interns. We hope to also to be able to share these reports further to the management, more specific on hand hygiene and areas of improvement. And we hope also to maintain the culture of retaining the hand hygiene tool in all the departments so that they are incorporated in the system. That's all we have from Kitale. Thank you.
Hello, Dr. Koech. I think we lost you at the end. Are you there?
Yes, sorry. Hello.
Okay, I think you, unless it is on my side. Lydia, are you able to hear Dr. Koech? Can anybody hear Nancy Koech?
Hello, Eric, this is Lois. Yes, I
Yes.
could hear her until she finished, she concluded. So it may be on your side.
It's maybe on my side. Okay, fine. Thank you, Lois, for the confirmation. So thank you very much, Dr. Koech, for taking us through the Kitale journey. And that is quite comprehensive. I could see you really jumped from a very low percentage to a very high one within a very short time. So I just have some questions inbox. And if we have any other, you can actually continue populating. And then we can actually, you could take us through and we can discuss a few things. So the ones I have, let me just read to you. You can actually write them down. I'll start with the first three and then the others. So the first question is, you said the program ended in 2020. Why did it end? So I'm sure the listener is asking, why did the program end in 2020? Then the other question is, how did you manage to rise from 3% to 50% from the start, to mid-January to mid of the year just before COVID? So how did you manage to rise from 3% at baseline to 50%? And then the other question is, there's only one sink at casualty. Is it enough for all the clients who come to casualty? So if you can. Respond to the first three, then.
Thank you so much for those questions. On the program ending in 2020, I meant the 3-year program that was supported by the Ministry of Health, MOH, and ITEC Kenya. So the program that they were supporting in terms of IPC in Kitale ended in 2020. But in terms of IPC activities going on, I think they actually jump-started for us the IPC program, which is going on at the moment. We haven't stopped the IPC program. So on the how to improve from 3% to 50%, it took a lot of trainings, as I've said. When the partner came in 2016, we were at 3%. So they actually came and introduced the IP practices and culture at Kitale with trainings and sensitizations, is when we managed to improve from 3% to above 50%. So it was continuous improvement. It didn't happen over a short period of time, but it took some time before we got to 50%. Actually, it took almost 2 years. The other question was our casualty having only one. The hand wash point at the casualty, the one that I was talking about, is the point of care that's inside the casualty, but outside we have a hand washing point for our clients. But I agree there's need for more hand washing points as a casualty. Thank you.
Thank you very much. So I'll go to the next set. What was the baseline of the sinks at start? That is going to be the first one. And then are the dispensers automatic or manual? That is number 2. And then what is the source of the hand hygiene commodities? Who buys them for you? Is it the county or the facilities, e.g. soap and alcohol-based hand rub? Back to you, Dr. Koech.
I'll start with the questions on dispensers. The alcohol-based hand rubs that we have are automated in most departments. Also, although we still have some departments who still have the manual dispensers. On the source for our hand hygiene commodities, our hand hygiene commodities are supplied both by the county. At the moment, the county sources the hand hygiene supplies for us. But in case we have any shortage from the county, we supplement by the facility purchasing the commodities. The things at the start, I think we have a member from the IPC department in Kitale, Julia. Kindly respond to that.
Julia, you can unmute and respond to that. Over to you, Julia.
Henry Ogaro. So for the baseline sinks at Kitale, I don't have the data with me of the quantities we had at the start. Maybe for next meeting, the feedback, but they've been improvement from where we started and where we are now. Thank you.
Okay, thank you. Then these questions on the chat. Besides posting the results on the information board, what else is the facility doing to improve and maintain good hygiene practices? So besides posting the results on the information board, what else is the facility doing to improve and maintain good hygiene practices? Then there is this other one. Doctors performed better than any healthcare workers at your facility. In other studies, they perform less dismally than the other cadres. Kindly explain what you did to your doctors. Thank you.
Thank you for that. Aside from posting the findings from our hand hygiene audits, we also involve the management in informing them of our performance so that they ensure they support the hand hygiene journey in terms of providing the necessary resources and commodities. We involve the various departments. In each department, we at least have one trainer of trainers on IPC, who they work in bringing together their department to make sure they're compliant, not only in hygiene, but also in other areas such as waste management. Aside from that, we continually do and monitor and perform on-job trainings on hand hygiene. We go around daily as the IPC team to observe what is happening and correct where there's a mistake. So I think that's what we've been doing. And on our doctors being on board on hand hygiene, I think the advantage our doctors had here is the advantage of numbers. You find that the nurses are quite a numbers data analysis. their percentage a bit low, but with continuous reminders to our doctors, and also with the help of COVID-19 around, I think they're more observant on practicing hand hygiene. Yeah, thank you.
Thank you very much. I think there's a question on the chat that says, kindly share with us the hand hygiene tool. I think I read something like that, if it is not getting lost. Yeah, then, so the hand hygiene observation tool at KCH use is the WHO one that anyone can download from Google. Okay, that one, Lois. They actually want, somebody actually wants the tool. So Lois, just speak a little bit on the tool and how it can be downloaded. Lois Kihungi, one of our experts in IPC, if you can unmute, you can actually speak a little bit on the tool and how somebody can get the tool to be able to use it.
Hi everyone. I was actually the lead person the Kitale IPC CQIP, and it's the tool that has been adopted for us, and that is the hand hygiene hand washing points and all the alcohol-based hand rub dispenser, ward infrastructure, hand hygiene, and for observing the practice is called hand hygiene observation tool, which if you Google WHO hand hygiene tools, you'll find and you'll be able to download. And it is not modified. Kitale and other facilities, they use that tool the way it is because it's very user-friendly and it gives you a good indication on how you are performing as a facility. Over.
Thank you very much, Lois. I lost you at one time, but I'm sure you explained that there are two tools. Yeah, one for observing the practice and then the other one for hand hygiene audit. So yeah, they're all available. And if you cannot download, just share your email on the chat box, and I'm sure one of us will be able to forward it to you. So for the one who asked the question, you can actually share your email. I think it's Priscilla. Yeah, we can just forward you the two tools. So thank you very much for responding to that. I think there's a last question that has come here. Let me just read it to you. In your report, you've said you have 3 full-time staff. How are you managing with the perennial shortage of staff in government hospitals? I think that one goes to Dr. Nancy.
Thank you so much. As I mentioned earlier, with involving the management, both at the hospital and the county level, they were able to post the 3 full-time staff to the IPC unit. So I think with the support from the management, it's possible. So aside from that, the IPC committee team are very active, and they are involved in most of the IPC activities.
Okay, thank you. Thank you very much. You've been able to respond to all the questions that I had. Unless somebody else has a question that he needs to or she needs to ask, you can just unmute and ask in the next 30 seconds. I'll give you 30 seconds to unmute and ask before we proceed on. So if you have a question that just unmute and ask. Martin, are you speaking? Okay. I don't seem to hear Martin from my side. Can anybody hear Martin?
There
Okay.
is no one is speaking. Except you.
Oh, okay. Yeah, because actually he had unmuted, so I thought he was speaking. So thank you very much for that. Dr. Rachel, are you able to unmute at this time? Dr. Rachel Kamau? Okay. Thank you very much. It seems Daktari's network has really failed. And I think I just want to thank all who attended. We've had quite a very good experience from Kitale Hospital being given to us by Dr. Nancy and her team. You've done a marvelous job. I know many people talk about the Kitale experience. Thank you for sharing with us. I'm hoping that the same information in the upcoming IPNET conference, so that now, there we will have a better platform for you to be able to share your outputs and ask so that people can ask questions, and you can also, be able to, enlighten us on the good practices that are happening at Kitale. So thank you very much for sharing with us your story. So for the rest, I'm hoping everybody is ready for the conference that is going to be the third week of March. For the ones who have not registered, you can get in touch with the Lydia. Lydia, you can actually share your contacts on the chat box so that now the people who need to be able to attend the conference can get adequate information from IPNET. The IPNET conference is coming up, so kindly make sure that you are part of the big team that is sharing on IPC and AMS practices in the country. And for the ones who are here, kindly add a link where you can actually give your feedback about the whole training that we've had today. So kindly just click and share your feedback, where we need to improve and what we need to do for making these presentations better. So at this time, I think I will thank all of you for attending. Linus, are you still on board? Dr. Linus?
Yes, I'm here, Eric. Hello.
Okay, yeah. Dr. Linus, you can give us a parting shot before we break up. So over to you, Dr. Linus.
Thanks, Eric, and thanks for moderating the session. I want to thank each and everyone, and most so Dr. Koech and Kitale team for sharing their experience and the journey, and I think it's a learning experience. I can see Dr. Jane Gitai. I'm sure they should be able to share their journeys of some facilities that IPNET has been supporting. They are how they are moving on. And I think this a learning area where each and every one of us is able to learn what is happening, the challenges that they have. And I think one of the congratulations I have for Kitale, and I think this really a learning for all of us, is just to know that they have now established an IPC department. They have 3 full-time staff. So I think Kitale, I should say, number one, because KNH, they have a full-time, although KNH is big, they have 11 staff. So you should be ahead of them because you have 3 staff. That's, I think, Echo, we can clap for you. The other one that I know has really established a good IPC, it's MTRH. And of course, these are national facilities, but county facility referral like Kitale, having 3 staff, full-time dedicated, and I think we'll be able to see more happening from there in terms of the AMR, AMS, and IPC activities. And I think now it's really one of the other things that just for all of us and for Kitale, to now incorporate the patient safety statutes, and I think the ministry has some guidelines on about patient safety and what needs to be done, and the 3 members plus your focal persons per department will be able to help that. The other thing I really want to congratulate is I think now every county has an IPC focal person. So those focal persons, they are the one now to agitate, and you have seen now Kitale has done to really like in the county referral hospital, at least to have full-time IPC staff. At least there's a lot of work for that person. And the WHO guidance is every facility that is 200 beds should have a full-time IPC person. So for all of us who are here and you are working in your facilities, if you are in the county and you know for your facilities have 200 beds and they don't have a full-time IPC person, with all the challenges about employment, and we've learned a lot from this COVID really. Let's take advantage of that and let's establish a strong IPC AMR program. So with that, I want to thank everyone who has made this a success. Lindia, Lomina from India and the team, Lindia for coordinating, and especially the speakers. It's unfortunate the other speaker lecture and the challenges. I hope that Lindia, you'll try to book her again so that we can continue and hear what she has. And I'm sure this will be very good learning because as we know, lecture has been the county CEC for Nyeri, and there's quite a lot to learn from our experience and being at the helm of the county. What challenges and how they have been able to move along. So with that, I want to say thank you and God bless you, and back to you, Eric.
Thank you very much, Dr. Linus, and thank you for the parting shot. So to everybody that has supported the team, thank you very much. We hope to see you next time. Dr. Rachel, you will still present to us next time because it's one of the sessions that we cannot miss. So I'm hoping that, yes, as Dr. Linus has said, we will be able to get in touch with Dr. Rachel. There is somebody who's asked whether there is sponsorship. Yes, kindly get in touch with Lydia. If you need to come to the conference, Lydia has shared her contacts, and there are several ways that you can attend the conference. So kindly get in touch with Lydia and share your experience. So thank you very much. Thank you, Romina, for all that. And thank you, team. Thank you, Dr. Jane, also. Can see you. Thank you. There's Happiness from Kisumu. Thank you all. My colleague, Care, asanteni sana for attending this session. Romina, say hi and bye.
Thank you so much, Eric, for that mention. And thank you, Dr. Linus, for your kind words. So I think with that, if we are done, should I go ahead and close the session for today?
Thank you. Thank you. You can leave at your own place.
Sure. Thank you so much, Eric. Thank you, Lydia.
Asante.